in those patients, the vitality returns back to their life, and that is something very beautiful about liver transplant. And in the last 15 years, the picture of liver transplant in the country is dramatically changed. Previously, there were like 2, 3 surgeons who were doing, one in the north, one in the south, one in the west. But now you have in each cities, you have got a good number of liver transplant surgeons. So a lot of liver transplant is happening. There is a lot of awareness being happening about deceased donor transplant. And also when it comes to hepatitis B and C, there is a lot of in the last 15 years with the advent of the directly acting agents and good therapeutics, the picture has changed. So to speak on this topic of viruses to vitality, hepatitis B, C in liver transplantation, it is my great pleasure to introduce my colleague, Dr. Aishwarya. Dr. Aishwarya has done her DM in infectious disease from All India Institute of Medical Sciences, AIIMS, New Delhi. After which she has worked extensively in various hospitals. She was formerly a consultant in infectious disease at Apollo Ahmedabad and UN Mehta Cardiology Institute. After that, an assistant professor in infectious disease at Institute of Transplant, IKDRC Ahmedabad, which is India's largest public sector transplant center. So she has an experience of working on the ground with transplant, and currently she is working as a consultant in Bangalore, Aster Hospital, Whitefield, and RV centers. So, and she has always been a good speaker right from her residency days. I have known her as a colleague from then, and I am also looking forward to this. There are a lot of gray areas when we talk about liver transplant in hepatitis B and C, and many times we feel that the ID may be a side actor, but it is very important to have an infectious disease perspective in this important topic right from the journey of liver transplant. So over to you, Dr. Aishwarya, for this topic.
Thank you, sir. Humbled by that introduction. So just confirm if you can see my slides.
Yes, yes.
Okay. So I would like to thank Praveen sir and Manipal Institute for providing this opportunity to me today. So we'll be discussing liver transplantation and the influence of hepatotropic viruses around this particular intervention. So the outline today would be just a brief introduction to liver transplantation and the circumstances that surround it. And then we will delve into optimizing hepatitis C and hepatitis B patients for liver transplant, and then managing them post-transplant also. And also considerations regarding accepting seropositive organ donors for transplantation in but mainly liver, but also other solid organs. So I would like to start off this presentation by a brief note on Dr. Thomas Tarzell. He was nothing short of a revolutionary in the last decade who has completely turned tables around for the liver transplantation scenario. So like we all know, kidney has a form of replacement therapy, like patients can be on dialysis until they wait for an organ, but that is not the case for patients with chronic liver disease, unfortunately. So this was his words. The history of medicine is that what was inconceivable yesterday barely achievable today, and it often becomes a routine tomorrow. And that's what he actually did in his lifetime. So after years of experimenting on animals, the first human liver transplant was done in 1963. The first 5 liver transplant patients, all of them succumbed, but he never let go of his hope. And he had his first successful human liver transplant in 1967. And not just his surgical techniques, but he also was the first one to establish the clinical utility of cyclosporin and later tacrolimus as immunosuppressive therapy for maintenance of solid organs. And these were later FDA approved also. So he is appropriately called the father of modern transplantation and liver transplantation. So the indications of liver transplantation is obviously end-stage liver disease, of which from the Indian data, the majority is metabolic syndrome associated fatty liver disease. That is 42% of the all patients who undergo transplant for end-stage liver disease. Another 20-25% comes from alcoholic liver disease, 15% from hepatitis B related CLD, 10% from HCV related CLD. Other causes include autoimmune hepatitis, cryptogenic causes, and then the patient priority, the listing for transplant, all of that is based on the MELD sodium score. Other causes include acute liver failure, that is drug toxicity or fulminant viral hepatitis, in which they can undergo urgent liver transplant, or hepatitis C, it's HCC, that is hepatocellular carcinoma related indications for transplant, in which they should fulfill the Milan criteria, that is either a single lesion less than 5 or multiple lesions, that is 3 or lesser, each measuring less than 3 centimeters. And then sometimes you can even use other modalities like radiofrequency ablation and chemoembolization to reduce the size. You should make sure there is no extrahepatic extension of disease or vascular complications because of the malignancy. Some rare genetic causes. Wilson is relatively more common. Others being alpha-1 antitrypsin deficiency, hemochromatosis, glycogen storage, the urea cycle disorders. All of those can also sometimes land up in liver transplants, sometimes in combined liver kidney transplants. Rarely PBC PSCs are also, because of the cholestatic complications, they land up in liver transplants. And among vascular causes are Budd-Chiari syndrome. This is just a short list, not the entire list. So hepatropic viruses, when we say HAV and HEV usually cause acute illness. HEV can occasionally cause chronic carrier state in patients who are immunosuppressed. Otherwise, hepatitis B, C, and D are known for their chronicity. Other groups of viruses like herpes viridae and adenoviruses and many others also, like dengue virus, are also hepatotropic and cause ALF. But then herpes and adeno are more relevant in the immunosuppressed context. So from the data from the INASL and NCDC, if you look at the prevalence, hepatitis B prevalence is around 3% of the general population, as compared to HCV, which is 1% of general population. But if you look at the numbers of all cirrhosis, around 10 to 20% of all cirrhosis is because of hepatitis B, and 12 to 20% of all cirrhosis is attributable to hepatitis C. So the cirrhosis burden is mostly equal between the two, despite HBV being more prevalent than HCV. And when we look at the hepatocellular carcinoma, close to 50% is because of hepatitis B. And despite cirrhosis being the same, HCC in HCV is around 12 to 32%. So let's look at the reason why that is so. The natural history of hepatitis B. So once exposed in an adult, around 90% will spontaneously clear the infection, and around 9 or 10% will go into fulminant, 1% into fulminant, and 9% into chronic hepatitis B, of which another 4.5% will go into chronic and 4.5% will clear the hepatitis B. So roughly speaking, out of 100 patients, adults who are exposed to hepatitis B, only 4.5% will land in CLD, that is chronic liver disease cirrhosis, and a smaller subset go into HCC. In infants and newborns, the story is slightly different, where only 10% may spontaneously clear and 90% may go into chronic hepatitis B. But this population is now on the decline because of robust immunization at birth and during the infancy. The scenario with HCV is quite different. So acute HCV can either be symptomatic or asymptomatic. If 15% of all HCV is symptomatic, 60% of them actually go into chronic infection. Whereas here, the symptomatic ones usually clear, spontaneously clear. But in HCV, even in the symptomatic, 60% go into chronic infection. And if 85% of all are asymptomatic, 85% of that also lands up in chronic infection, and then progresses to cirrhosis and HCC over the next 1 or 2 decades. So that is why the proportions of CLD in HCV are more than that in HBV. And once they enter this cascade of events, we have 3 viruses at play: hepatitis B, HCV, and HDV also taken into consideration here. They go through inflammation, necrosis, proliferation, and then this could lead to tumor initiation. So they go into the cycle of fibrosis, cirrhosis, and finally hepatocellular carcinoma. In the hepatitis B viral infected liver, sometimes they can directly have hepatocellular carcinoma without entering the cirrhotic stage, without waiting for that 1 decade of cirrhosis to set in, because of the HBX gene of hepatitis B, which directly gets incorporated into the host genome and causes the tumor initiation genetic modifications. So that is why the HCC burden because of hepatitis B is far greater than HCV, despite the numbers of CLD. Okay, so this is one case scenario for consideration. So HCV and HCC, a 62-year-old lady with high HCV copy numbers, despite twice treatment of 3 months duration of sofosbuvir and velpatasvir, had presented to us for consideration for liver transplant. So she had no past history of ribavirin or NS5A exposure, and she had concurrent decompensated CLD and HCC, and she was a liver transplant candidate. So what would be the course of action here? Would you wait till the HCV PCR is negative and then transplant? So usually the thought process is any infection pre-transplant you want to optimize, you want to treat, and then once it is controlled or completely treated is when you want to take the patient for transplant. But would you think like that here? Or if you feel that she's been already retreated and we can't wait, she's decompensated CLD, you want to proceed to transplant, would you change the antiviral regimen here, or would you do any further tests? Any volunteers with any answers?
The chairperson has to respond.
Yeah. So you, anybody can answer, or you can say it in the chat box.
Yeah. So can I take this question? Yeah. So Dr.
Yes.
Aishwarya, basically we are trying to, so the idea is we can treat hepatitis C even after transplant. But the thing is, this is something which is treatment looking like a treatment resistant. So probably you want to add voxilaprevir, or if available, you want to switch it to glycoprovir and pebendazole. But again, if you have a decompensated CLD, that will become a contraindication. So either you can add ribavirin here to make it clear, but if you don't have that much of time, if you think the patient is deteriorating, you will take the patient for the transplant on treatment and probably add voxilaprevir on top of that. These are my thoughts, but if there is anything wrong, you let me know.
Excellent. So this was our plan also. So we initially thought we'll add ribavirin upfront, but then the patient had anemia and everything else which precluded ribavirin addition. So we did not add ribavirin. We just continued sofosbuvir velpatasvir. Fortunately for her, or fortunately for us, she was on the cadaver wait list actually, and in 2 months' time she cleared the viral copies. So maybe it was just an issue with compliance or the drug manufacturer issue or something of that sort. But fortunately for us, she cleared. But the logical action plan here would be to add ribavirin to sofosbuvir velpatasvir, wait for the organ, and as and when she receives an organ, add voxilaprevir in the post-transplant phase, because then the decompensated CLD is corrected. So that was our plan too. We tried to get voxilaprevir. We could not get it in the country. It had to be imported and would cost around roughly 1 lakh or so per month, which was also out of the patient's pocket. So that would have also been difficult, but this was a scenario. But then there is nothing that mandates us to wait for HCV clearance for transplant. That is very clear. So even if other than this scenario, when she's having this suspicion of resistance and all of that, if that was not even in the equation, even then we could go upfront for transplant. So the recommendations are such that MELD exception points or liver transplant not avoidable and imminent. So MELD exception here would be HCC. Over there, you can have an individualized decision making, and you could continue or even just start HCV therapy post-transplant also. You don't have to wait for transplant for HCV clearance. And also there is data to suggest that in patients with HCC, the clearance is slow. Once that HCC is either resected or the patient undergoes liver transplant, the HCV clearance is aided. It will be faster. Then if the patient is in CTP class A, you can wait for transplant. It's not really an indication for transplant. So you treat pre-transplant and you wait. Sometimes up to MELD 15 or MELD 20, you give antivirals. The MELD score can go down, and then the patient doesn't even require a liver transplant after that. So that is where you can benefit out of treating before transplant. And if at all required, you can also go for LDLT alongside. Whereas in those with MELD more than 20 and GFR 30, again, shared decision making regarding quality of life and access to transplant and all that. But if MELD is very high, preemptive treatment post-transplant. So you prioritize transplant here over treatment. Prioritize treatment here over transplant. Prioritize transplant here over antivirals. And then the middle is a gray zone where you can go with whatever comes early to the patient. So this was one study which compared outcomes in patients who were treated with DAAs pre-transplant and post-transplant. So what they saw was biliary complications were higher, significantly higher in those who received DAAs pre-transplant as compared to those who were treated post-transplant. Acute cellular rejection, not too much difference between the groups. And then they compared this with the anti-HCV titer, and the titer was much higher in the DAA treated patients who have cleared their HCV rather than those who received DAAs post-transplant. So how they are trying to postulate and explain this is, once the patient has received DAA, there is a lot of liver injury also in the process of viral eradication, and also because the virus is also getting, the cell is getting destroyed, a lot of neoantigens are getting exposed, and this will upregulate anti-HCV antibodies. This response kicks in after transplant when the immune reconstitution occurs. And because of this upregulation, there is greater risk of acute cellular rejection and biliary complication is what they have postulated. So this is just one interesting thought process. Probably you can wait up till transplant to give the antivirals. Okay, so just a brief overview of immunosuppression in liver transplant so that our decisions can be well informed depending on what other drugs and immunosuppressed state the patient will be. So just overview what happens in liver transplant. The donor APC will on MHC2 or MHC1 present the antigen to the T cell receptors, that is CD4 or CD8 as the case may be. And then the downward pathway will ensue, and then finally there might be immunological attack on the graft. So this is one thing which is T cell mediated. The other is donor specific antibodies. So if it is a sensitized patient for whatever reason, either they have received multiple blood products in the past or previously transplanted and now undergoing a retransplantation, they might have antibodies, and then you can do tests to see if it is donor specific antibodies. If they are, then they'll have a greater risk of rejection and they will have to be managed differently, that we will see in subsequent slides. But so what will happen is these DSAs will respond to antigen presented on MHC2 on the graft. And then subsequently there is complement activation and direct destruction, or complement and this antibody will attract all their friends, that is NK cells, macrophages, neutrophils, and through the innate system also cause destruction, and you can have graft injury. But what is different between liver transplant and kidney transplant? This is important because the immunosuppression is also different in these two scenarios. The HLA class 1 expression, which is seen in all the cells in the body, are high in both liver and the kidney. This is responsible for hyperacute or acute rejection, and it has low ABMR risk. That is, antibody-mediated rejection is lower. HLA class 2 expression, which is associated with antibody-mediated rejection, is high in kidney, but the expression of class 2 molecules is limited in the donor liver. And therefore, the kidneys are more susceptible to, more sensitive to DSAs, that is donor-specific antibodies, and especially DQ2, which causes a lot of graft loss. These are mostly chronic or late rejections. And the liver per se has a very tolerogenic immunobiology. By what I mean to say by that is, it produces molecules such as soluble HLA to neutralize the alloantibodies, or HLA-G, which is an immunoregulatory molecule or inhibitory molecule which is present on biliary epithelium, which is resisting the immunological attack. Or because it's a part of the reticuloendothelial system, it can delete the alloreactive T cells. Because of all of these factors, liver is less prone to rejection as compared to kidney. So our immunosuppression will also be in that extent only. So if we look at the interaction between the APC and the T cells, there are mainly three signals that we target, the same old pharmacology class if we can recall. So signal 1 is between the MHC and the T cell receptor. Signal 2 is the co-stimulatory molecules, and signal 3 is the interleukin 2 and interleukin 2 receptors. So the targets here for therapy can be classified under 3 headings. One is T cell activation inhibitors, that is either calcineurin inhibitors, cyclosporin tacrolimus, or CTLA4 inhibitor, that is belatacept. And the next one is the T cell depleting agents. This is usually used for induction therapy. So you can have anti-CD52, alemtuzumab, or ATG, or muromonab, which was previously used, not used nowadays, or T cell proliferation inhibitors, which are either the mTOR inhibitors, sirolimus, everolimus, mycophenolates, or azathioprine. So in T cell depletion are the agents which are used for induction, and maintenance are combination of the activation inhibitors, usually cyclosporin tacrolimus, along with proliferation inhibitors, mycophenolate, azathioprine, or mTOR inhibitors, and you can taper down steroids. So in liver transplant, usually induction therapy, if the patient is having a standard profile, you start with steroids at the anhepatic phase. Anhepatic phase is when the recipient liver is removed and before the donor liver circulation starts. So once the circulation is through, the anhepatic phase ends. So till during that duration, a steroid, higher dose steroid is given. So the dose is exactly not fixed. Many groups, many schools of thought exist. Some people, they start with 1 gram, some people give 500, some people give 250, 125, depending on their own center experience. And this is just to bridge through the initial phase. You don't give anything that is more stronger than a steroid for induction and liver transplant usually. And then you start off with a CNI, that is tacrolimus. And that is around the time when the patient is recovering post-op in the ICUs. And then you gradually add an MMF when time permits. So the one thing that you should keep in mind is liver transplants involve a lot of blood loss, much more than a kidney transplant. Kidney transplant is almost no blood loss. So that kept in mind. And plus the ischemic reperfusion injury is another important thing to keep in mind, because especially in the case of deceased donor liver transplants. So because of all this, you can have a circulatory collapse, you can have some inotropic requirement, you can have AKIs in the early post-op phase. So in such cases, you may not be able to introduce a CNI upfront right at the start. So you might want to consider basiliximab in patients where you expect such complications, or those who have had HRS or concurrent AKI pre-transplant but not requiring a combined liver kidney transplant. And again, in patients with sepsis, CMV infections, leukopenia, severe diarrhea, accordingly, you'll have to adjust the immunosuppression. And then moving on to the maintenance phase, the standard would be to taper prednisolone over 3 months. You taper MMF to the minimum required duration over a 6 months to 2 year period. And then you continue the CNI or mTOR inhibitors at the lowest trough level. And you might modify it according to the side effect one might observe in the patient. And you keep evaluating for side effects which are known to be caused by these immunosuppression agents, and monitor and treat pre-transplant pathology. If everything is favorable and the graft function is stable, you consider minimization. So this is usually started around 1.5 to 2 years, and you keep minimum possible immunosuppression. There are some schools of thought which also want to encourage the tolerance protocol and keep the patient on no immunosuppression absolutely and see how long the liver might survive. But these are under very close monitoring and mostly under study purposes, not routinely practiced in general practice usually. But there are few indications where steroids have to be continued for longer. That is when the etiology for transplant was autoimmune hepatitis, or the patient is undergoing a retransplantation, previous history of rejection, and ABO incompetent transplant. So patients with other risk factors like high sodium MELD, or it was an urgent transplant, patient with frailty, sarcopenia, acute GI bleed prior to transplant, concurrent renal dysfunction, HRS, sepsis, portal thrombosis, donation after circulatory death, where you're expecting more of ischemia in the organ, otherwise metabolic syndrome, thoracic ascites, that is hepatic hydrothorax, ICU, prolonged ICU ventilatory support, high surgical risk. So these are all patients that constitute critical patients where you might want to give a stronger induction, and then you might want to delay tacrolimus. You might have to delay tacrolimus. You might not have too many options here. So in such patients, you want to give slightly more immunosuppression to save the graft, where your go-to would be tacrolimus MMF or tacrolimus everolimus, and avoid tacrolimus monotherapy. And then later you optimize the doses, and you might want to consider CNI-free regimen if at all you encounter side effects because of tacrolimus. Okay, just an overview of how rejections are managed. So T-cell mediated rejection, usually proven by biopsy. You optimize the background immunosuppression, and then if there is no improvement in the liver tests, or if it is a biopsy proven moderate to severe rejection, usually a methylprednisolone pulse is given, followed by a taper. If there is no response to that also, then you have ATG as the only other option. In antibody-mediated rejection, you usually look for histological grade of rejection and or the DSA titers. And initially what you want to do is optimize the background immunosuppression. If the patient is on cyclosporin, you want to shift to a more potent tacrolimus, assess response. If there is no response, methylprednisolone pulse and taper. Again, if there is no response, specifically for antibodies, you have options like plasma exchange or rituximab. And if it is chronic rejection, you don't give any pulse, you just increase the dose or switch the maintenance immunosuppression from cyclosporin to tacrolimus. What complications would you expect after liver transplant would be ischemia, reperfusion injury, vascular complications. In up to 10% of transplants, you might have hepatic artery thrombosis, which will present very similar to sepsis with multi-organ dysfunction. You might have AKI, you might have shock, you might have high spiking fevers, and all the inflammatory markers are up. You might end up titrating all antibiotics and giving him maximum support, but the patient will eventually succumb if he does not receive another transplant. You might try anticoagulants here, but it may not work quite often. 20% of patients may land up in biliary complications. These are more chronic and very morbid, like biliary leaks, strictures. Otherwise, you have infections in the early and delayed phase, rejections, recurrence of the primary pathology, or side effects because of the immunosuppressions. So considerations in organ transplantation. So the scenario today, I don't know why Praveen sir selected this date for my talk, but it was very fortunate to be today, because yesterday, 13th of August, was the World Organ Donation Day. And the theme for this year is answering the call. So there is a huge gap between the number of available organs and the required number of organ donations in the country, where India has remained at 1 per million population organ donation rate since more than a decade. And to achieve self-sufficiency, we need 124 per million population, which means on the waitlist mortality, around 20 patients die every day, and around 44% on the list annually succumb without receiving an organ. So the graph is showing a stark difference, especially in the kidneys and the liver, patients waiting for kidney and liver or donations. And what the US saw over the last 2-3 decades were an uptick in drug overdose deaths, mainly because of the opioid abuse and overuse. And concurrent with this addiction is the HCV positivity. So among all donors there, 8.2% were anti-HCV antibody positive, and 4% of them were actually even PCR positive. And what is known previously, before the DAA era, was that a NAT positive organ will 100% lead to viremia in the transplant recipient. And at that point in time, what would happen to HCV with immunosuppression was not known. We didn't have effective HCV medications, and untreated HCV would land the recipient in fibrosing cholestatic hepatitis, cirrhosis, HCC, extrahepatic manifestations like glomerulonephritis. And these complications occur in double the speed in immunosuppressed patients as compared to usual. So if it would take 10 years, 15 years for a normal patient to land in complications, a post-transplant patient may land there in 4 to 5 years' time. So this was a deal breaker. And the discard rate between 2005 and 2014 of such organs were around 500 kidneys per year, just because of HCV positivity. So people wanted to change the scenario around HCV and came in the direct acting antivirals, which was a boon. So the first trial was Thinker trial, which transplanted HCV positive kidneys into negative recipients, carefully selected, and a detailed consent process was done. 10 recipients who received 10 donations, which were high quality kidneys with KDPI 42% and HCV positive. Post-transplant, all of them were started on antivirals and given a full 12-week therapy of antivirals, and all 10 achieved SVR12, that is sustained virological response. So this was promising. Subsequently, this was replicated in other centers. 53 recipients all were negative for HCV at the end of 12 weeks of therapy. Another 23 recipients, again, all of them had 100% sustained virological suppression, and the grafts all did very well. So this was very promising. Again, bigger numbers, 65 HCV negative, 59 HCV negative recipients, out of which 65 received positive organs. And the graft was doing well. Rejection rates were comparable. DSAs were slightly more in those who received HCV positive organs, but did not lead to any clinical consequence. And again, the DGF, everything else was statistically similar, and sustained virological response was seen in 100% of cases. And we have a 3-year data from the US registry, transplant registry, where the outcomes were not different between HCV positive and HCV negative donors. This was replicated in other organ transplants, like in the heart. Out of 10 recipients of HCV positive heart, 9 of them were HCV free. They attained SVR. One succumbed actually to a complication, a rejection, but otherwise everybody else had an SVR. Similar picture in the liver. 10 HCV positive liver transplants were done to HCV negative recipients. 100% graft survival, 100% SVR, and no evidence of DAA associated hepatotoxicity. And because of these positive outcomes, the number of centers that practice D plus R minus HCV transplants have also increased. Number of transplants have also increased. And even in complicated situations, like those who need MCS bridging, that is those with LVAD or ECMO requirement prior to heart transplants or dialysis support, acute rejection, length of stay, all of them, all of the outcome parameters in patients, even with critical conditions prior to transplant, they did well despite the donor organ being HCV positive. So this is the evidence summary of liver. Near 100% SVR achieved, except for one study which showed 96 and 94% in liver and kidney respectively. And among other organs, we can see that almost all kidneys were 100%. The ones which show some 89% and 90% here are mostly just the heart or the lung groups, which are showing 80 and 90%. So the heart lung group, the transplant group, looked deeper into it as to what further can be done. So if the liver is to be accepted from such HCV positive, obviously we have to make sure that there is only an acceptable degree of liver fibrosis. In the lung, they also have an additional ex vivo lung perfusion and additional ultraviolet C radiation, which can be tried to reduce the incidence of HCV seroconversion post-transplant. But anybody who's receiving an HCV positive organ, we should have a plan for what we would do if there was persistent HCV viremia. Suppose the DAAs fail. Suppose there were some resistant strains. And if we have to add ribavirin, but we are not able to add because of post-transplant anemia, or what is the possible risk of HCV transmission to other contacts, household contacts of the recipient. And another one particular aspect in heart recipients is drug interactions, specifically between the DAAs and amiodarone, where you can have a combined increase in bradycardia incidence because of the interaction. So that is something that one should keep in mind. So this was the idea prior, that if they are NAT positive organs, we upfront give preemptive DAAs. If it is antibody positive, and if we are waiting for the NAT, then either if the organ is NAT negative, we can wait for the recipient NAT. Only if it is NAT positive, we add antiviral. So this was what is the school of thought. And then we have some more clarity now. Some studies are also looking at short duration of DAAs. In this study, they looked at only 7 days of DAAs post-transplant, and they had a good result with nobody seroconverting to HCV. So the recent approach to this is, if you're having an HCV positive donation, if the recipient is NAT negative, you just continue surveillance with at least 1 and 3 month post-transplant HCV testing. Sorry. And if at all the recipient turns NAT positive, you have two options. Either you give an upfront prophylaxis for short duration. So sofosbuvir velpatasvir given for 4 weeks or glecaprevir pibrentasvir for 8 weeks in the immediate peri-operative period. Or you can have a preemptive strategy where you continue to do HCV viral load testing every 4 weekly. And so this was the, this is not the recipient NAT, this was the donor NAT which was positive. Recipient, if he is NAT negative initially, you just continue testing, and if and when he turns NAT positive, you can give preemptive strategy where you will have to give a therapeutic duration, complete 12 weeks of antivirals. So short duration prophylaxis versus preemptive full duration therapy, depending on the NAT positivity in the recipient. So this is the latest approach on HCV. So we now move on to hepatitis B scenario, where we have a 57-year-old mother who is an ABO compatible probable kidney donor to her 30-year-old daughter with CKD5D. On evaluation, she was found to be surface antigen positive for hepatitis B, E antigen positive, and the copies were 2000 international unit per ml. Her AST ALT was normal, USG liver was normal, there was no fibrosis on the fibroscan. We didn't do a biopsy. So what would you tell this donor now, probable donor now? Would you accept the organ? If yes, what is the plan for the recipient? Or would you treat the donor because
Anybody
it's a
from the
living
audience
donor?
would like to answer?
Sorry? Hello?
Yeah, anybody from the audience? It's a precious organ. What would you do? Praveen, would you like to add anything?
Yeah, so basically patient is like waiting for a kidney donation. So in kidney recipients, it is easy because you can always treat the donor and then clear the viremia at least, then vaccinate the recipient and make sure that the anti-HBs antibodies are like more than probably 100 international units, then go for a transplant. Because she's actively viremic. If it is liver transplant, the scenario will be a little different, but then you but in kidney transplant, we do have time. The patient can be continued on dialysis unless there is some other indication for emergency indication. But if the patient is anyway has to take the kidney transplantation, hepatitis B can be transmitted even through kidney. So patient has to be on one thing is she has to be vaccinated if it is possible, and then patient should be on antivirals after that, probably for lifelong.
Correct. Any take on HB immunoglobulin, sir?
So in liver transplants, we try to keep the immunoglobulin levels quite high initially. Probably initial first 1 week, probably we'll try to keep it above 500, followed by 100, more than 100 per month. But in liver transplantation, I'm not sure. I think vaccination followed by in kidney transplantation, vaccination followed by antiviral should be enough in kidney.
Correct. But does this donor actually require treatment for hepatitis B here? If she was not a donor, would you treat her for hepatitis B?
There is no fibrosis. See, the thing is this: when we have a HbA1c positive, any patient for that matter, if the viral load is more than 2000 international units, there is a subsequent risk of hepatocellular carcinoma. Right. So even if it is HbA1c positive with a viral load of more than 2000, will become an indication for treatment.
Okay, so the guidelines are still not explicitly told that.
Wasim, sir? Dr. Wasim, sir, anything to add?
No, I think as of now, as of current guidelines, no treatment required. But then there are like
the cutoffs are like
process going.
Yeah, the cutoff is once HbA1c negative, you take a cutoff of 2000. HbA1c positive, probably 20,000 is what we keep on speaking. But there is a lot of evidence to show that so basically we are trying to say that this patient might clear off after 6 months. That's what we are trying to say by saying that HbA1c is positive and viral load is this much. But if this viral load of 2000 is persistent, then there is a risk of HCC in this patient. So I understand that there is some controversy, but so when we say that HbA1c is positive, we take a higher viral load. That means that we are expecting that virus to get cleared in next 6 months or something. So that's why we have a lower threshold for HbA1c negative patients. But again, this patient is 57-year-old. So that will become a kind of a relative indication for the treatment with this viral load.
And also, if she is a CKD patient, and
Yeah.
maybe on the list also. So, would you want to put her on because she would have to be on lifelong antivirals? So, in a non-liver CKD patient, would you avoid this donor, Aishwarya? Where we have
Sir,
an option of waiting and
yes.
putting on a list.
Yes. So we did not start antivirals for this mother, the potential donor upfront, and we did not agree to go with the transplant upfront also. What we advised was to give another schedule of vaccine to the recipient, see if her titers were maintained satisfactory levels, and then probably we'll wait to see if the mother clears the virus or not, or maybe we'll treat her at that point in time. If another, maybe 3 months later, another copy is done and she's still not clearing, or maybe 1 or 2 months down the lane we can see if she's clearing the copies. If she's not, give her antivirals and then we'll go upfront. So that's what we decided for this particular case. But in case this was a very precious organ, maybe what if this was a heart, and what would you do then? Or what if it was a lung donor, what would you do then? A deceased donor call. So just to look into those scenarios, this was a real case, but just complicating the situations further, I just wanted to discuss the other organs also. So this is the overview of the natural history of hepatitis B. So the first antigen to present would be HBs antigen. The next would be HBe antigen. It spikes later but falls earlier, and then the anti-HBe also comes in. The HBs AG clearance takes much longer. The first antibody to be positive is the core antibody, which persists throughout. It would be IgM in the acute phase and switch over to IgG class if it is chronic hepatitis B. And depending on this, we divide it into multiple phases. So the HBeAg positive, chronic infection or hepatitis, HBe antigen negative, chronic infection or hepatitis. And the last phase is HBsAg seroconversion, where HBs antigen is disappearing and anti-HBs is also appearing. So then this is a completely recovered situation. Or the patient can occasionally have occult hepatitis B, which is a persistent focus. So now this compared to HBV DNA and ALT. Now, although this is a chronological graph, this part of it is not exactly in continuum or chronology. So the patient can fall in any of these particular phases at a given point in time. So if the DNA is high, but the ALT is normal. So this is what was previously called the immunotolerant phase. Here, usually there's not much inflammation or fibrosis in the liver, and you don't need to treat these patients upfront. You can probably wait for virological clearance. Phase 2 is where the DNA is high and the ALT is also high, and by virtue of the immune response, you will have inflammation and fibrosis. This is the immune clearance phase, where if the DNA numbers are particularly high and the cutoff that is recommended by guidelines is more than 20,000, you have to treat this patient. Phase 3 is where everything is silent. The DNA is low. The inflammation is also low. So the ALTs are also low. But because of chronic infection, you can have background minimal activity and fibrosis in these patients. Again, you may want to wait here. You need not necessarily treat unless you're having a demonstrable amount of fibrosis or other risk factors like HCC or age related or family history of HCC. In phase 4, it is HBe antigen negative chronic hepatitis, where the DNA copies are high and the ALT is also high. Here, it has been noted that despite E antigen being negative, the DNA copies need not even reach as high as 20,000. Even at levels of 2,000, you can have extreme fibrosis and inflammation and rapid progression of cirrhosis. So this is definitely an indication to treat. And then in the last phase where the patient has seroconverted, you obviously don't have to treat. So apart from these two, phase 2 and phase 4, where you have indications to treat, you have other conditions such as pregnancy, where even the early, the high DNA and low ALT situation may require treatment to prevent transmission to the child. Or in cirrhotics, or those who are on immunosuppression or on chemotherapy, you might have to treat regardless of the phase that the patient is in. And in patients who are going to receive profound immunosuppression, even for occult hepatitis B, you want to give antivirals to prevent a reactivation. So this was just an overview for treatment. So probably our patient was fitting into HBe antigen positive but low DNA, and she was having no ALT response also. So she was not even really here. She was actually probably clearing the infection. So not an upfront indication to treat, but rightly, like Praveen sir pointed, if she continues to have those copies, even if it is 2000 only, theoretically there is a risk of HCC, greater risk of HCC, and at least for that indication now people want to treat. And this is not yet part of the guidelines, but this is a new school of thought. So if we give these sort of HBV positive organs to other recipients, what would be the outcome? So that is what we call de novo hepatitis B, where the recipient previously did not have hepatitis B. So there are two situations why this can arise. One is transmission of hepatitis B from the donor for obvious reasons. The other is a reactivation of hepatitis B, which was probably a recovered, previously exposed to hepatitis B, and the patient has seroconverted or has an occult hepatitis B, which because of transplant immunosuppression is now reactivating. So what are the odds? So in a liver transplant recipient who is anti-HBs negative, that means he's completely non-immune. If you're giving a hepatitis B positive organ to this patient, hepatitis B positive liver to this patient, the risk of de novo hepatitis would be 60 to 80% to acquire hepatitis B infection now. And with intervention, it can be reduced to 10 to 12%. Those who have vaccine immunity, the risk is around 18 to 20%. And with intervention, it can be reduced to as low as 1 to 3%. Or patients who have anti-HBC positive, core antibody positive, this is either resolved or resolving acute infection, occult infection, or false positivity. To a great extent, I think we should have ruled out false positivity in such situations. The risk of DNH would be 10 to 15%, and with intervention, it would reduce to 3 to 4%. And those who have natural immunity, this is the best case scenario where the core antibody and the surface antibody is positive. The risk of DNH is least, 0 to 5%, but the intervention doesn't do much. So in this situation, if you happen to develop either a reactivation or a new hepatitis B infection from the donation, probably your intervention doesn't reduce your risk by too much. So by intervention, what I mean is antibody or antiviral. So that is hepatitis B immunoglobulin or antivirals. So the first intervention to pitch in was actually hepatitis B immunoglobulin. And there was many different regimen of prescribing hepatitis B. Initially, people used to give a very high dose of hepatitis B immunoglobulin, which was 10,000 international units during intra-op, and then subsequently a smaller dose, 600 to 800 international units, which was given every day for 1 week, then weekly for 1 month, and then it was given monthly. And this used to continue indefinitely. So this is an IV drug which was given for a prolonged duration, very costly, very inconvenient. Then came the antivirals. So they started combining antivirals with the hepatitis B immunoglobulin. So these rates are actually from around 2010 and 2011 systematic reviews, where the intervention was actually lamivudine combined with hepatitis B immunoglobulin. So probably with today's antivirals, that is entecavir or tenofovir, the rates could be much lower than this in reality. So liver grafts from core antibody positive donors. So what if the donor did not have HBsAg positive, did not have the active hepatitis B infection, but had a core antibody positive? So over here, if the recipient is having HBsAg positive with or without HDV, concurrent HDV, what you do is you give the nucleotide or nucleoside analogs along with hepatitis B immunoglobulin. HBsAg positive recipient, HBIg along with a combined nucleoside analog. But otherwise, in those who are having no immunity at all, or those who are having vaccine immunity, just the nukes would be enough. You don't need to give an immunoglobulin. And those who are having natural immune response, where the risk per se was 0 to 5% and intervention was not doing much difference, 0 to 5% where they had the risk, that group, even if you don't give any prophylaxis, it is okay. You can just monitor the patient whether they happen to develop HPV copies or not, and not give any upfront nucleoside analogs. And whether to discontinue or not is the other question. So the ATS guidelines recommends discontinuation after 1 year if they have persistent immunity, that is anti-HBs titer more than 10 international unit per ml. But the BTS guidelines ask to continue nucleoside analogs indefinitely wherever indicated, not in this scenario, but in other situations to continue nucleoside analogs indefinitely. And then the patients have to remain in close follow-up. So you do an HBV DNA with or without HBsAg. So there are some situations where only the DNA may come and the surface antigen is not detectable in blood. In some post-transplant settings, you have only HBsAg, and for certain reasons, the HBV DNA is not detectable. For example, if immunoglobulin is already being given concurrently, this may be HBsAg may be bound to immunoglobulin and cleared out. So your HBsAg may be negative and DNA is detectable. And sometimes you can have just DNA positive. So both ideally need to be tested once in 3 months for 1 year, and then every 3 to 6 monthly. And this is going to continue lifelong if they receive a positive donor. And a follow-up of a few such transplants between 2000 to 2015 showed that 43% of patients who received anti-HBC positive organs, out of which 108 were HBsAg negative recipients. And they saw that 64 were on lamivudine, 44 on entecavir. 3 people had de novo hepatitis. So the risk was around 2.8%. And this has been the number even across the globe. In different countries that have replicated this model, usually it is around 2.8%. 10-year patient and graft survival is around 80%, which is reasonably acceptable for liver transplants. And the anti-HBC positive grafts versus anti-HBC negative grafts did not have much difference in graft survival or patient survival. So this situation, if we translate it to a kidney graft, so in renal allografts, in non-immune recipients, that is anti-HBS and anti-HBC, everything negative recipient, receiving a core antibody positive renal graft, the DNH risk would be 20 to 30%. That is less than half the risk of a liver recipient. So this one should keep in mind. So in non-liver grafts, what happens is in any antibody positive, that is either vaccine immunity or natural immunity, no prophylaxis is required. But if a person is completely non-immune, anti-HB core negative, anti-HB surface antigen negative, you might want to consider antivirals. That is, in that time it used to be lamivudine. Now you can use entecavir or tenofovir for up to 1 year, and hepatitis B immunoglobulin is not necessary. Same like the previous situation. And the BTS guidelines even goes on to suggest that lamivudine prophylaxis can be stopped after 6 months of therapy if the patient is not HBV positive in that interim. Okay, so now what would you do if it is HBs antigen positive organ? So there is a huge difference between core and antibody being positive and the organ actually being surface antigen positive. So ATS in 2015 gave a sort of conservative guideline where individualized risk assessment needs to be done, do a donor liver biopsy and rule out by histology that there is no significant fibrosis. And the recipient obviously would be on indefinite prophylaxis with entecavir or tenofovir. One thing that stands out as a difference between ATS and BTS is in ATS, HB immunoglobulin is considered in all recipients with titer less than 100 international unit per ml. Whereas in BTS, so HBsAg positive organs should not be given to HDV positive recipients. We'll deal with this in the subsequent slide. In the meantime, you can also offer these organs to anybody in need of an urgent transplant as a life-saving measure, because organ with HBV is better than no organ at all and death, right? So that can be definitely a rational decision. But they don't recommend HB immunoglobulin because it rarely achieves HBsAg clearance. So this is not something that we give to clear hepatitis B from the graft, but it's to prevent establishment of hepatitis B as a new infection. So it doesn't have too much role when the recipient is also having HBsAg positive, which are the usual recipients of HBsAg positive organs. So going back to this chart where the donor is HBs antigen positive, you would prefer to give it to an HBsAg positive recipient itself, and you would just continue nucleoside analogs. To somebody who is HBsAg positive and has concurrent HDV, it is not recommended. So why is this? This is because you already have the entire mechanism for establishment of an HDV disease. So probably this patient would now be on antivirals. You're giving a graft which is not having HDV, but having surface antigen. So this HDV can easily infect that graft. It will act as a super infection of HDV over hepatitis B, and it can accelerate fibrosis and cirrhosis in the graft. So you can lose the graft very quickly, very rapidly, as short as 2 to 3 months post-transplant also. So that will be a futile experiment. So that is why it is not recommended. And in other recipients, so those who are natural immunity, you can give high barrier nukes. Those who are completely non-immune, try and avoid an HBsAg positive because they can have very high flares because of immunosuppression. Those who are having vaccine immunity in selected cases. So see how the anti-HBs titer is. Is it satisfactory? Do you want to give hepatitis B immunoglobulin? All of these decisions can be taken into consideration and then considered in patients at least who are having vaccine immunity. So transplantation in recipient with hepatitis B. So now before 1990s, after transplantation for hepatitis B related CLD, the graft which was incoming, which at that time was usually an HBV negative graft only, the reinfection rates used to be more than 80%. So when you are taking a patient for liver transplant, you want to see that their survival, 5-year survival, all causes included. So anything else, any other concurrent illness, malignancy, everything else included should be more than 75%. So comorbid conditions, everything taken into consideration. So if your transplant is not even less than 50% is going to be a 5-year survival here, then again, this is not a worthwhile transplant. But then came hepatitis B immunoglobulin, and this reduced the mortality by 19%. It was a small improvement, but still it was considerable at the time because they didn't have effective antivirals. So preventing post-liver transplant HBV recurrence in somebody who's already harboring HBV. So in HBV-related cirrhosis, the patient would be on entecavir or tenofovir. Previously would have been lamivudine or adifovir for a short duration. So now they are on newer generation antivirals. So what you would do is ideally check HBV DNA levels at liver transplant. Obviously, you can't wait for hepatitis B to clear for clearing the patient for transplant. Patient might even have good loads of hepatitis B DNA. But if it is negative, that's the best case scenario. Just continue antivirals and you don't need any hepatitis B immunoglobulins. But if it is a detectable HBV DNA, then you have two groups. One with a low viremia, less than 2000 international unit per ml. There you assess the patient's risk for a recurrence post-transplant. So risk factors would be drug-resistant hepatitis B, that is past exposure of lamivudine sometimes can lead to drug resistance, HIV, HBV co-infection, HDV, HBV co-infection, or HCC concurrent at the time of liver transplant. So these are risk factors. And also add to this non-adherence and all other risk factors, drug-induced, such that you're having to give a low dose of antivirals, all of those also. So if these risk factors are there, then you want to give HBIg also at the time of transplant. So a high dose, that is 10,000 international unit, is given in the anhepatic phase, followed by 600 to 1000 international unit IM every day for 7 days, and then weekly for 1 month, and then monthly as long as your target is maintained above 100 international unit per ml. And then subsequently there was another modification to this. So people said this initial regimen is all right. Give 10,000 followed by 600 to 1,000 for the first week, and then monthly and all that is okay. But after the first month, what we can do is keep checking the titers. If the titer falls to less than 100, you give a dose of hepatitis B immunoglobulin just to boost the titers. So that was called on-demand hepatitis B immunoglobulin. So that is one more technique of managing immunoglobulin just to reduce the costs. Some people give subcutaneous or intramuscular, intradermal immunoglobulins also. And then you keep testing for hepatitis B DNA by PCR and HBsAg before every dose of immunoglobulin, before every monthly dose of immunoglobulin. And you can only discontinue immunoglobulin once the DNA and HBsAg is entirely undetectable. So this can take really, really long given the immunosuppression and the chronicity of the hepatitis B infection. So the BTS 2018 guideline also says the same thing, that if hepatitis B and D co-infection is there, we have to give immunoglobulin along with nucleoside analog prophylaxis from the time of transplant. And then the immunoglobulin in BTS guideline is continued at least for 12 months. So this is one timeline that they're given, which others not necessarily follow. And there is a lot of interest in hepatitis B immunoglobulin free regimen now, obviously because the antivirals are doing much better than the earlier times. And it is very cumbersome to keep receiving IV injections, and the cost associated with immunoglobulins are also going to be from the patient's pocket. So the first groups that studied this was Fung et al. And Vadwan et al., where 80 and 75 patients were included. These were patients with hepatitis B receiving liver transplants. There was no hepatitis B immunoglobulin given, only the oral agents. So here entecavir was given by one group. The other group evolved, the antivirals evolved over time, starting from combination of lamivudine and adafovir, then only entecavir in 42, which was the majority group, tenofovir in 12, and a combination of entecavir and tenofovir in 2 patients. So the recurrence rate, actually the Fung et al. Study showed 23% recurrence, whereas the Vadwan et al. Had only 8% recurrence. So this was very reassuring. While all others were testing for short durations of hepatitis B immunoglobulin, 7 months, 6 months, 7 days, 12 months, this was a stand apart where just 8% recurrence was seen with no immunoglobulin at all. So when they studied these 2 groups in detail, what they found was this Vadwan group actually had low risk patients. So that is how the risk stratification actually came out, where the hepatitis B DNA should be either undetectable or less than 4 log, E antigen negative, good compliance, no HCC, no HDV co-infection. In these patients, you can even entirely skip the immunoglobulin. But if you find any such risk factors in your patient, you might want to go ahead and continue the immunoglobulin. And then subsequently came many more trials with either discontinuation strategies after day 5 or after a few months, or no hepatitis B immunoglobulin at all. So the largest studies are 265, 362 patients by Fung et al., where almost 100% of the patients had DNA undetectable and 92% had HBsAg undetectable also post-transplant. Then that is the longest follow-up time also of 59 months after liver transplant. So what happens when these hepatitis B positive patients receive non-liver solid organs? So obviously they can have a flare because of the immunosuppression. That goes without saying that the antivirals have to be continued. But those who are core antibody positive, that is past recovered and having a CLD, they have otherwise maintained their hepatitis B status, they are also at a risk of reactivation now. So here you can consider a 6 to 12 month antiviral prophylaxis, or keep them in close monitoring with both surface antigen and DNA, and start a preemptive therapy as and when it becomes detectable. This is the South Asian transplant infectious disease guidelines from our region. So the recommendations here are that donation with surface antigen positive and IgM core antibody positive, this is acute hepatitis, obviously they will be excluded from donation. Those who have surface antigen negative but IgM anti-HBC positive, probably they are in the window period, again avoid donation. And if the donor is having just IgG core antibody positive and surface antigen is negative, they recommend to check for the nucleic acid amplification, that is PCRs. Only if PCR negative, they are asking to accept the donor organ. But I think we have more evidence from the West, and if at all it is a precious organ, we can look at other strategies where we accept the organ and do the needful, that is give antivirals in the post-transplant phase. So thank you. I think if there are any questions or any discussion.
Thank you very much, Aishwarya, for the excellent talk where you have taken us through the journey of the clinical progression of hepatitis B, C to appropriate selection of HBV and HCV positive donors, and how do we manage in HBV positive recipients, and how about the de novo. So excellent talk. You had covered all the corners, and it would be interesting to see all the questions from the audience. A couple of comments from my side that something we need to understand is different from the West in our country is that their programs are majorly deceased donor related. So all the studies there from the Western literature would be about no DDLT bias, but as compared to that, the Eastern side in our country, especially more than 90% of our liver transplant are living donor transplant. So we come up with all these situations that come across. And also cost is a major concern, especially using immunoglobulin, because many of our patients are on a tight budget crowd-funded patients who have only money just for the transplant. So in any studies which would like help us in avoiding immunoglobulin even in the high risk areas would be much welcome. If if because many of these old studies where HBIG is recommended were in the time of lamivudine.
Yes.
There be even the the guidelines of 2020 because entecavir and TAF was not that readily available in those times. So with now this powerful with high drug resistance, barrier of resistance, I think it will be interesting. And most of the centers have now gotten away with HBIG, except in very selected group. So from now, any questions from the audience?
So basically, I would like to ask you both of you, like, ideally, we want a hepatitis B CLD patient to be probably not viremic at the time of transplant, but many times it is not possible because it takes a long time for them to be negative, or sometimes we still see a low-level viremia despite of antivirals. So if you are taking him for transplant, do you want to just continue antivirals only, or you want to give immunoglobulins at least for some period of time?
This is for hepatitis B or C, sir? Because C may you just have to continue antiviral.
B.
Hepatitis B positive recipient.
So basically, patient is hepatitis B CLD, and you are going to transplant him. But before the transplant, he is not DNA negative. He's still viremic.
Correct.
So you are putting a new organ which is hepatitis B negative, but there is a high risk of reinfection to the new organ. So at this point of time, if the patient is still viremic, do you want to just give antivirals, or do you want to combine it with hepatitis B immunoglobulins?
Yes, sir. So that was the last graph that I was describing, where you want to check the DNA. If DNA is less than 2000, then you look for risk factors. Only if there are risk factors like Hep B, HDV co-infection, or HCC was your indication for transplant, where the clearance can take a lot of time, or the viremia can recur even after transplant. Meaning to say, HCC can also recur after transplant because of some occult meds. The other things being adherence issues, or if the patient was in ACLF at the time of transplant. So in these sort of setups, you want to give immunoglobulin also alongside antivirals. But otherwise, if your copies are more than 2000 also, you want to give immunoglobulins along with antivirals. But if the copies are also low, if the risk factors are also not there, or if they are DNA negative but still surface antigen positive, you can just continue antivirals.
So what is the immunoglobulin protocol which you people are following? Like, how do you do it? Or is it the call by the transplant team usually?
So it will vary from center to center. So some people do give a high dose of immunoglobulin, the 10,000 unit immunoglobulin. Some people give it only at the time of transplant and till the initial first month, and then they drop it off. After the first month, it is not given. So it will vary from team to team. What is your experience, Wasim sir?
So I have at my center we have not used for like I have been part of more than 300 transplants and around 30 hepatitis B related, but fortunately most of them were controlled. And we did not require hepatitis B immunoglobulin for any of them. But then the reduced one that you showed is what most of our colleagues agree on when it is needed.
So we have also not given immunoglobulin for uncontrolled HBV viremia. We've given it mostly for indications like the donor is positive. So in our center, we used to have more of diseased organs, and mostly because the incoming organ is positive. In a negative donor is where we have given immunoglobulins, but not for uncontrolled viremia.
Okay, so basically hepatitis B positive donor to D plus R minus. With hepatitis B, you usually give immunoglobulins with antivirals for the recipient.
Wherever indicated, yes, sir. That's also only for HBs AG positive. Even in core antibody HBS positive, yes, HBs AG positive. Or you're accepting the organ.
So with the core antibody positive donor and recipient being anti-HBs positive. So do you look for the titers or any specific titers like more than 100 it has to be there or more than 10 achieved? That is good enough not to give antivirals.
You want to keep 100 as target there, sir.
Okay.
But at our centers, even in those patients we have, though I know in the most of the studies it has been shown that when the titers are high, for the intervention doesn't work, but that no, people still keep the patients on antivirals.
So even with the anti-HBs positive, the patient will
Yes.
still receive antivirals if the donor is a HBsAg positive. That's what you're saying.
Yes.
Core antibody positive, yes, sir. You won't
Yeah,
give
core
immuno,
antibody positive. Yeah, core
you'll give
antibody.
only antivirals.
So the best scenario for a core antibody positive would be to give it to somebody with HBsAg positive. That would be the best. And then the one with
All positive.
with anti-HBs more than 100. But we still give antivirals in that situation. It's a center to center based decision, but at our center we still give antivirals. Any more questions? We had long. There are some questions in the chat box. So let me. Tenofovir preferred or lamivudine for prophylaxis in donor core anti-HBC in renal transplant. Aishwarya, would you like to take that question?
We prefer newer generation only, sir. Tenofovir or entecavir. Lamivudine, the rates of resistance would also be high on treatment, so we don't prefer lamivudine. We give tenofovir or entecavir.
Yeah, and we have TAF now and entecavir both. So no, the nephrotoxicity is not much of a concern. The barrier to resistance is very high. So I think TAF and entecavir, lamivudine is out of question now. One question, it's more about a logistic question about where to send HDV viral load. Do you have any idea? Aishwarya or even Praveen, you can answer.
No, we
I have
don't.
not sent anywhere.
Yeah, I don't know.
So we don't routinely do HDV also, but we don't even give organs to these patients also. So the HBsAg positive is where this question of HDV or not comes. And that is also introduced by the BTS guidelines in 2018. The ATS guidelines does not even look into HDV. So no, it's not commonly done.
Are you looking into like a positivity of HDV? That's what I think Dr. Ankit is trying to
Antibody
ask.
also we are not doing routinely, sir.
So it
HDV
is not.
antibody we are not doing.
And what? Yeah.
Yeah, go ahead, Praveen. Yeah.
What about the treatment duration of hepatitis C if you're starting treatment after transplant?
12 weeks, sir. 13 SPR.
Do you just give it for 12 weeks or you continue it for like 24 weeks or something? Extend it a little bit? No?
No, 12 weeks. They will attain SVR generally. And the response is actually more robust in post-transplant. They clear more quickly as compared to pre.
So I
Any
think the
specific?
part that
Sorry, sir. Go ahead. Go ahead.
Yeah, the part that Aishwarya discussed about it being so what we are trying to achieve is more important when we are treating HCV pre-transplant, because in those with child A and low MELD, there is a strong possibility that you treating the HCV may make the patient not require a transplant. But on the other hand, when you are dealing with B and C, it will just improve a couple of points on MELD score, and but still the patient will require transplant. And there have been studies which have shown that in child C, especially in MELD score more than 27, the failure of regimen is high. So the response, sustained viral response is not achieved. So in this situation, if we have started the patient pre-transplant, then we achieve some sort of a control and then go for transplant, and then post-transplant we treat them. Because ribavirin in most of the situation, tolerance and all, it becomes an issue in this situation. So the achieving SVR pre-transplant in high melders and is difficult. And secondly, in HCC, also there is a lot of a time bound because they have to fall into, usually they are downgraded to Milan or UCSF criteria. And if you wait for a long time, then the patient may become non-transplantable from the HCC point of view. So in these two situations where decomp CLD with high MELD and HCC, we prefer treating post transplant rather than pre-transplant, where the response is robust then. Any other questions, Praveen, or anybody from the audience? Aishwarya, I have a couple of things. So we discussed about HBS AG positive donors in DDLD setting. Do you ever in a LDLT liver transplant, would you ever dare to ask a patient with HBS AG positive?
Actually, even in DDLT, I think they are refused. Most often the organs are refused.
No. Anytime now the desperate patients take it in DDLT when you know the
heart and lung they accept, but liver and kidney, when you have living donors,
liver I have seen more willingness to accept if the donor is recipient is ready to take. Because in living donor, the safety of the donor also becomes an issue. If we have to be very sure that there is no risk of progression to CLD in the donor cell.
Do you have any experience or HBsAg positive living donor liver transplant?
No, we have not done, but there are a lot of patients who come forward and in a desperate situations for their loved one. So it sooner or later that may arise a situation. But in that situation, what we had a discussion about it multiple times. So in a very careful situation where biopsy is not showing any fibrosis, there is no virologically suppressed kind of a patient, maybe we can take a chance, but it's a difficult situation. Okay, and so we have covered most of the points. So Praveen, any other questions?
So I just wanted to ask, like, if you are taking a recipient with active viremia with hepatitis B, do you tweak immunosuppression a little bit, or you go with the conventional whatever you're giving? Like, do you change anything? If some of the centers are using basiliximab to delay the calcineurin inhibitors initiation, especially with hepatorenal syndrome. So do you want to come down on something, like you want to decrease the dose of total immunosuppression, or you leave it, like just start antivirals and wait?
So in viremic patients, we prefer like the minimally required immunosuppression is.
At your center, sir, is it routine to give basiliximab for induction and liver transplant?
We have hardly used basiliximab.
And what's the initial dose of steroids which you are using?
So you depends upon, usually 500 or 1 gram is given initially, and then they come down.
That is on table.
Yeah, and then they come down gradually. So also one point that I want to make is the timing of starting post-A of hepatitis C treatment. So usually what our center we prefer that by the end of the first week, means the acute problems of post-operative period are settled, like the ileus and your early rejections and all that. That sort of your LFTs also come down. So how we start our valganciclovir prophylaxis if needed, or so at the end of the first week is what we start, and we have been giving the 12 weeks only.
Same, sir. Around 5 to 7 days usually, post transplant.
Yeah, I think we can wind it up. Thanks, Dr. Aishwarya, for this wonderful session. It's really good. I think we will have more sessions with you. Yeah. And Washim sir, thank you for all your knowledge sharing here.
Thank you, Praveen, for the opportunity. Thank you for all the participants for being part of this.
Yeah.